And this is part 3 of the Orthopedics module for third year students in Xavier University College of Medicine. So, Orthopedics, we already presented this outline. That's a review of the muscular system. We have covered this in the past two parts, and we'll be discussing today the orthopedic history and physical examination. So, orthopedic history and physical examination, we'll be looking at the overview. We'll be discussing history, physical examination, and diagnosis as well. Tests. This part should just be a review of your PDR2, your physical examination and history taking in second year. So orthopedic surgery encompasses the entire process of caring for the surgical patient. Although the surgical procedure is the itself a key step towards helping the patient, it is the preliminary and follow-up care that determines whether the surgery is successful. So history must address the key features of the problem, particularly medical problems and those with other possible clues to requirements for billing purposes. Social history and past medical history are similarly important. And again, the physical examination must cover the essentials that are necessary for diagnosis, and frequently the confirmation of the diagnosis is based on the physical examinations. But such considerations as skin condition and blood supply must also be documented, and despite the fact that this process is also part of your surgical evaluation. So orthopedics is a unique mix of surgical and non-surgical options. The history is still the most formidable tool. History and PE is still the most formidable tool in an orthopedist arsenal, and it helps determine the direction of either towards diagnosis or and treatment. As I mentioned, should feature the key features of the problem, and consistencies in the history should be checked with those findings in your physical exams and further verified by your diagnostics. So history, we start with your identification because some age-specific conditions such as congenital diseases as compared to degenerative conditions. You also note your gender because there are some gender predispositions, particularly in multiple myeloma in males, slip capital femoral epiphysis in males, and development dysplasia of the hips, rheumatoid arthritis, and osteoporosis in females. Occupation usually gives a clues to causation in the repetitive trauma conditions, and physical requirements that the patient needs are subjected to. Other data like your religion, education, hand dominance may help in the planning your patient care. Chief complaint basically is what brought the patient, and it's also important to note the duration. If there are too many chief complaints, then you need to prioritize either by order of duration or which one is most bothersome. Then you continue with the history of present illness. You have your then past medical history. It's important to note the drugs the patient is taking as well as allergies to food and drugs. Personal history may give you a clue on what to further ask and what diagnostic and therapeutic options you may have for the patient, as well as social history and family history. Other parts of the history we should also consider are menstrual history in women, and if you're treating pediatric patients, it's also important to note birth history and particularly milestones. By milestones, we mean time the patient is able to stand, time able to walk, time able to talk. Some delays in these milestones may give a clue to the condition of the patient. For the history of present illness, some diagnostic facts should be enumerated in a chronological order as much as possible because we can consider if it's either congenital, developmental, infectious, metabolic, traumatic, mechanical, or degenerative, or idiopathic in nature. So we ask if it's been present since birth, some fever, chills, or night cries, and if you're considering infection. If we're considering metabolic, we can ask for nutrition status, some hormonal imbalance. We could also ask for seasonal variations in the symptoms, like inflammatory signs, some morning stiffness, if we're considering inflammatory causes. For traumatic causes, it's important to note if it, the history of road traffic accident, fall, the nature of the trauma. If we're considering mechanical or degenerative, it's important to note if advancing age, if the pain is improved by rest, any instability or locking sensation, and if we're considering constant pain, we could consider uh, some sort of metaplasm. And if there's no obvious complaints, usually we can attest this to as an idiopathic type of disorder. So pain, we describe it in the OPQRST, if you can still remember from your beats. So onset, if it's sudden, what happened, what was the patient doing. P, progression, if it's constant, if it's worsening, has it improved, is it on or off. Q is for quality, if it's aching, stabbing pain, burning pain, throbbing pain. There's R is for radiation, if it's referred pain, is it the pain coming from the heart or diaphragm, from the neck, or in our particular orthopedics, if the leg pain is coming from the back, which could indicate sciatica, or some back pain that could be related to a kidney stone, aortic aneurysm, or an ulcer. S is for severity, could be either be mild, moderate, or severe, or if you can put in a pain scale, timing and duration, so you can note when was the first onset, how long did it start. We also note swelling, onset of swelling. If it's rapid, we may consider some hematoma or hemarthrosis. If it's slow onset, probably some infusion or some infection or even a tumor. Uh, we could ask for limps if it's causing the patient to limp or if been observed to be limping. So we can ask if it's painful or it's painless. Could be a traumatic kind of limp. We could also consider some inflammatory type of limp like TB hip causing some specific type of limp and even in some infection like poliomyelitis or even in osteoarthritis. You could also consider limp in dysplasia of the hip, a deformity in the joint or bone, some leg discrepancy, or even if the patient has undergone some sort of surgery for either the hip, knee, or ankle. We should ask for some deformity noted. Basically, if it's sudden onset, we can consider some trauma, some subluxation, dislocation of the joint. If it's associated with some muscle spasm, and if the deformity is gradual in progression, we may note this in some growth-related disorders. Stiffness, we should note the joint involvement, uh, particular in some cases like TB, myositis, and septic arthritis. Should also note for some weakness or what we may termed as loss of muscle power. So this could be either be neurological in nature, could be myopathic in nature, or connected to your muscles. If there's a sensory loss, uh, could be simple myopathy or even motor neuron disease. Weakness that is sudden usually points out to a traumatic cause, while weakness that is progressive may point out to a neuropathic or myopathic cause. We also ask for discharges. Discharges we mean by if there's a persistent discharging sinus, which could be found in diabetic foot, diabetes mellitus, osteomyelitis, fungal infection, or even foreign bodies that has, that has been lodged in the area, causing some form of discharge. It's also to note that in some malignant cases, there's presence of discharges as well. The other things we need to ask for are the ADLs, or your activities of daily living, if how the signs and symptoms of the patient has affected his daily activities, like getting up, sitting down, using the bathroom, combing hair, and also particular, what we ask for is the treatment received. If the patient went to a traditional bone setter or the helot, has taken other treatments from other doctors. As one particular example, if he or she has been taking some steroids or prior uh, pain medications. Review of systems is also important to note that we include only the positive history and the relevant negative history. So for the physical examination, the particular order is we inspect as the particular dictum. We see, then before we move. So inspection, then palpation, then we check for strength or power, then do a range of motion, then the neurovascular examinations, and lastly we do our special tests if there's any. It's also important to always remember that when you state this when you document this, you give the exact location. When you have to compare with the contralateral side, and you have to check if it's consistent with the history, and always include the joint above and below. For inspection, we check for the particular mnemonic for this is SE seeds, or S for swelling, E for erythema, A for atrophy, D for deformities, and S for scars or skin changes. Palpation, the mnemonic is test for CA, tenderness, effusion, swelling, temperature. You check if it's hot or cold, or particularly in some inflammatory cases. Check for crepitus to check for atrophy. Always remember when you're checking for effusion or swellings to measure distances from a landmark. So particular landmarks you can use is the olecranon, the belly button, the knee, the patella, the ankle. And if you have some sort of swelling, it's important to do a fluctuation test and transillumination test if you're able to. Range of motion, we do this active and passive. So range of motion, particularly, we use this instrument. If you're not familiar with this, it's called the goniometer. Basically, it's just two protractors with their long arms. Then you check for the range that is available in the patient. So we check for active. Active, we mean that we ask the patient to move. So we ask the patient to move first. We observe if there's anything. We observe for the range, or if you have a goniometer, you can check what range is available. Then you try to do it yourself. Sorry, this is passive. Passively, you're the one moving the limb of the patient. So this is active range of motion, which means the patient is doing it himself or herself. Then passive is the one where you try to extend the range and check for the end feel. So the following are the range of motions of the upper extremities. So shoulder joint, the flexion is 0 to 180. The elbow joints noted that there's limit just to movements flexion and extension to 0 degrees. It's also important to know in some people that are what do you call this? Hyper flexible. They can go into some degree of hyperextension where they can extend beyond 0 degrees. So wrist movements, you have your flexion, extension, radial deviation, and ulnar deviation. So for the lower extremities, you have your hip joint, your knee joint, and your ankle joint. So for strength of power, we ideally do assisted isometric testing. So you ask the patient to move either against your resistance. So we give this following grade. So basically, no muscle contraction is 0, contraction but no joint movement is 1. 2 is with gravity eliminated. 3 means that the patient is able to move it against gravity only. But when you put some sort of resistance, even how small, the patient won't be able to do so. So grade 4 or 5 basically is your normal muscle grade, because in some cases 4 would be, it depends on the resistance you're applying to. So next is your neurovascular examination. This is your P2RST, the mnemonic for this. Pulse and capillary fill time. Power, we already mentioned. Reflexes, the sensation or the dermatomes, and the tone. So pulse and capillary fill time, as you can recall in your baits, you check for your pulses. Your fill time should be less than 2 seconds. Power, we already mentioned the muscle strength. Reflexes, by now you should be able to elicit this in your patient, as well as the sensatory sensation and the dermatomes. And last, the tone in the joint or net limb. If it's a hypotonic, hypertonic. And lastly, we do special tests specific to the area. So if you're checking the knee, you can do your Lachman test, check for your ACL. It's also important to note to do some malingering tests, particularly in this patient complaining of back pain. So when you ask the patient to lift the leg or the leg that is affected, usual response to that is if it's really weak, the patient will try to compensate by uh, pushing down on the other leg. So that's a good sign. Malingering, they don't usually, they just pretend that they can't lift their leg. So if you're interested in this special test, there's actually one book by McGee. It's the Orthopedic Physical Assessment. Uh, if you have classmates or physical therapists or occupational therapists, they should have a copy of this book. You can download this, I think, online, either legally or illegally. It's one particular book, so I won't be dealing with the special test, and this should have been discussed during your second year. So at this point, after history and PE, you should have a working diagnosis. So diagnosis, we ask for further evidence, so we can ask for radiographs, which is the bread and butter of diagnosis in orthopedics. As I mentioned, you check for the joint above and below, because this acts as, you also ask for not just one view, but two views, AP and anterior and posterior and lateral view because this gives you a 3D visualization of your patient. So in particular cases, you may need to ask for a contralateral x-ray if needed. So in this case, this is a pediatric patient. You can see that this one is not a fracture, actually your physis, but this one, there's a particular fragment here that is not seen in the unaffected arm. The physis, as I mentioned previously in our previous lectures, could be mistaken as a fracture in small children. You can also ask for special views like your stress views and your skyline views. Stress views is basically you do the x-ray while the joint is in a stress position. So you hold it in place, you hold the ankle in place, you uh, push the push it this way to create some sort of stress in this area. As you can see, there's some widening on the x-ray, so this could point out to some instability in the ligaments in this area. You can also ask for skyline views. Skyline views basically for the knee. You can check for your patellar alignment. So this could tell you the relationship for your patella over your femur. So you can see some widening over this side. Next is we can request for CT scan. So some occult fractures we can see on CT scans. And there's what we also call some 3D reconstruction with CT scan. CT scan can also we can use if there's an implant in place, a metallic implant, because as we all know, we can't use an MRI for metallic implants. So this is an example of your 3D reconstruction. So you can see this in the normal CT scan, you can see this fragment. But on 3D CT scan, you can actually see the fragment in detail and its relationship to the other structures. So this one is CT scan of the pelvis. This is a posterior dislocation. So as you can see, there's fragment here, and this is a view on top. You can see the femoral head coming out of the socket. Then the 3D reconstruction will actually tell you how big the fragment is and help you decide later on what to do with your fixation. MRI basically is the method of choice for detection of the occult fractures and significant acute fractures. And it's important to note that MRI is excellent if you want to view soft tissue structures like your meniscus, your ligaments, your tendons. So in this particular case, you can see this area here. In some cases where you don't see anything on x-rays, but you suspect that there could be a fracture, particularly in this area, femoral neck or a proximal femur fracture. You can see there's a fracture here, but there's minimal movement, minimal displacement. So as I mentioned, it's excellent for viewing your soft tissue structure. So here on the x-ray, you can see there's just a bone that's been chipped off from the the fibular head. But if you note here on the MRI, there's the bone fragment. Some collateral ligaments has been uh, frayed as well. So you just don't fix this fragment, you have to address this problem as well. Other diagnostic tools we can use, we have your radionuclide bone scans. Usually this is used to evaluate your skeletal activity. So there's the bone scan, there's lighting up of the area. So there's an occult fracture in the sacral bone that could have easily been missed on X-ray. One particular new tool, not particular we use, it's not really new, but it's been around, ultrasound, but the field of musculoskeletal ultrasound is increasing now. So inexpensive tool that being used can usually used in the shoulder, the knee. You can evaluate your the glenoid. You can evaluate your medial, lateral, the ligaments across. So we discussed orthopedic history and physical examination. So I gave an overview, the history, physical examination, as well as some diagnostic tools you can use in orthopedics. Your post tests. And thank you. See you in the next lecture.